Hello, and welcome to the Wiley podcast series, Knowledge to Impact, where medical education meets real-world change. This series aims to deliver latest content updates from our Knowledge Hub program. For part 2 of episode 1 on Cancer Cachexia, we are joined by Professor Jeffrey Crawford and Dr. Rony Dev to discuss the challenges in early detection, management, and illustrative case presentations of Cancer Cachexia. This discussion was originally broadcast as a webinar. A link to the original accredited activity, including information on how to claim credit, faculty disclosures, and the slide presentation, can be found in the show notes. We're glad to have you with us, and we hope you enjoy this episode.
I'm pleased to be here today with Dr. Aminah Jatoi, one of my colleagues. We'll be discussing Cancer Cachexia. I'll focus on challenges to early diagnosis and management strategies. Cachexia is defined by weight loss, but it's much more than a number on the scale. Weight loss is really the tip of the iceberg. It involves decreased food intake, weight loss itself, and of course, decline in muscle mass and subcutaneous fat. And it's all driven by inflammation that leads to a more catabolic state for the patient that underlies a lot of the visible changes. In addition, patients with cancer will have intolerance to treatment, increased fatigue, functional impairment, and increased mortality. So how does a patient develop cachexia? Well, it's not only cancer patients, but patients with any chronic illness such as heart failure, obstructive pulmonary disease, kidney disease, or infection can lead to cachexia. And the hallmarks of cachexia can include anorexia or loss of appetite, inflammation, an anabolic resistance that makes it difficult to gain muscle, endocrine dysfunction, and anemia. All this resulting in fat loss and muscle wasting, and ultimately reduced muscle strength, decreased physical activity, and actually sometimes impairment of respiratory function. So the complexity of causes contributing to weight loss are many. If we look at patient factors that contribute to weight loss, they include nutrition, physical inactivity, side effects of anti-cancer treatment, psychosocial situations, and age, all contributing to the weight loss, and factors from the tumor itself that lead to host response, such as systemic inflammation, endocrine dysfunction, and altered metabolism, may result in changes in appetite and taste and smell, altered GI motility, and reduced muscle function and mass, as well as reduced fat mass. We also have to remember that cachexia occurs with a number of overlapping states. They may include sarcopenia or age-related muscle loss, frailty, and malnutrition. And it's this complex situation we see in the older patient, often with comorbid disease and with sometimes disabilities, that all contribute to this complex cachexia. So a definition was developed for cachexia more than a decade ago by Dr. Furon, Dr. Jatoi, and other colleagues. It became the international consensus definition, which was multifactorial syndrome defined by an ongoing loss of skeletal muscle mass. It can't be fully reversed by conventional nutritional support and leads to progressive functional impairment. This definition is undergoing some revision and clarification to include fat loss, to include inflammatory changes and other biologic effects, but it still stands today as a very important guidepost for how we think about cachexia. And in its definition, we actually define cachexia as patients who have weight loss of greater than 5% of body weight in 6 months, or if the BMI is less than 20, then the weight loss of less than 2% would qualify. The importance prognostically of weight loss has long been known in cancer patients. I think it was clarified by Dr. Martin, who combined weight loss with body mass index in a large cohort of patients with advanced stage lung and GI cancers. And she graded the BMI decline and the weight loss increase in this schema you see here, so that patients with grade 0 BMI weight loss grade versus grade 4 had drastically different survival, going from 20 months to 4 months, just based on these two factors associated with weight loss. So we wanted to understand this relationship a little bit better, and we used a clinical trial database within the U.S. Cooperative Group System to look at lung cancer patients entering clinical study. Here you see patients without weight loss or less than 5% and greater than 5% along a range of BMIs. And you can see as the BMI declines and as weight loss increases, there's a drop in survival based, again, simply on these two factors in patients who otherwise would qualify for clinical study. So we need to be cognizant of both the BMI and weight loss, both in clinical practice and in our clinical studies. The recognition of cachexia can be difficult, not in a patient like this, where there's clear loss of intercostal muscles and fat. These are recognized easily in patients when they're seen, but the majority of patients don't have this overt signs of cachexia. And it's often the patient or the family member who bring to the attention of the clinician the problem of weight loss and what can be done about it. The difficulty clinically of recognizing muscle wasting is well recognized by this diagram. Here you see two patients, both with the same body surface area and the same BMI. The one on the left has sarcopenia as defined by a CT scan with software imaging that identifies lean body mass. The patient on the right with the same BMI and same BSA has a normal muscle background. So very different degrees of muscle wasting in these two patients that aren't going to be recognized clinically. And the importance of sarcopenia has been well established by Dr. Prado and her colleagues, as well as many others. And sarcopenia is present in the cancer patient. There's a decrease in survival. There's an increase in side effects of treatment. There's a shorter time to tumor progression. There's physical disability, higher rates of complications in the hospital, prolonged hospital stay. So it's a major factor for our patients to deal with. In 2021, ESMO developed clinical practice guidelines for cachexia, which they noted remains an underdiagnosed and undertreated complex condition, which includes both objective and subjective components, and occurs in approximately half of patients with advanced cancer. In a study presented last year by Dr. Rowland at the ASCO meeting, this was a large real-world evidence study of more than 600,000 patients whose EMR records were examined over a 5-year period. And what was documented was the amount of weight loss that occurred in these patients and related to individual cancers. So you can see on the left-hand side, patients with pancreatic cancer, the highest rate of weight loss at 71%. On the other side of the slide, thyroid cancer, the lowest at 23%. This is in the metastatic setting. And note that in green, these are patients without metastatic disease also experiencing weight loss, and there's a surprisingly high prevalence of weight loss in this population. This slide demonstrates the average months from cancer diagnosis to cachexia development. And you can see on the right-hand side of the slide, the types of cancers we associate commonly with cachexia, or cachexia is often recognized at the same time the cancer is diagnosed. On the left-hand side, we see cancers like prostate cancer and breast cancer, where the development of cachexia generally occurs after the diagnosis over the disease course of the cancer. This slide demonstrates the relationship of metastatic disease and weight loss to outcome in patients. These are different cohorts, but if we look at the slide on the left, you can see that in the blue line, we see patients with no metastatic disease and no weight loss, but their overall survival is most favorable. On the other hand, if we look at the red line, patients who've had both metastatic disease and weight loss, they have the worst outcome. In the middle, the green and blue lines, light blue lines, represent patients without metastatic disease with weight loss or no weight loss and metastatic disease. And it shows essentially that weight loss in the non-metastatic setting has a survival impact almost equivalent to metastatic disease themselves, emphasizing the importance of both weight loss and metastatic disease and the outcomes of our cancer patients. The ASCO guidelines for cancer cachexia were developed in 2020 by a group of expert panelists. At that time, based on the evidence available, the recommendations were limited, but they did include dietary counseling to be offered with goals of providing patients and caregivers with advice for the management of cachexia. As noted, there were no specific pharmacologic recommendations made at that time, although subsequently, based on additional data, olanzapine has been added as a potential intervention that could be considered. The evidence for nutrition is actually quite substantial. Early nutritional interventions can be associated with a reduction in treatment-related complications, better chemotherapy delivery, improved tolerability, improved quality of life, and better outcomes for patients. So it behooves us to recognize weight loss early and intervene early with nutritional interventions to try to improve outcomes for our patients. If we look at pharmacologic interventions, so things are a little bit more complicated. You can see that both ASCO and ESMO have mentioned these agents, megestrol acetate, olanzapine, and corticosteroids, as potential agents that could be considered, but note that none of these have FDA approval for cancer cachexia. All these agents have shown either temporary improvement of appetite or improvement in weight or weight gain, but none of these agents have shown an improvement in quality of life or functional improvement. And unfortunately, all three have significant potential side effects that have to be considered in the individual patient. So other approaches for cachexia include multimodal interventions. And last year at ASCO, the MENAC trial was presented. This was a large randomized open label phase 3 multi-center trial that evaluated a combination of exercise, nutrition, and anti-inflammatory medication over a 6-week period in patients with advanced lung or pancreatic cancer. Of note, the weight was stabilized in patients who were on the intervention arm compared to standard of care with a significant p-value. So it does speak to the importance of intervening with a multimodal approach for our patients, but it also speaks to the fact that there were no significant differences in muscle mass or physical activity, and speaks to the need for us to develop other therapeutic interventions to really improve the situation for our patients. I mentioned the olanzapine data. This was the study done in India that really led the ASCO group to decide to add this as a possible consideration for patients with cancer cachexia. Note that this was a group of advanced GI and lung cancer patients with cachexia. You can see the control group on placebo in red with a declining weight over time compared to the group getting low-dose olanzapine, whose weight improved over time with a significant difference of 4 kilograms over the time of the study. This strategy is being further explored in an NCI-sponsored alliance trial led by my colleague, Dr. Jatoi. And in this study, olanzapine low dose daily for 4 weeks is being compared to megestrol acetate, 600 milligrams per day, also for 4 weeks, to assess cancer-associated anorexia, to look at the efficacy of these two arms of the study, to look at toxicity and side effects, and overall benefit of one or other of these strategies. So the future of cachexia, I think, will be very dependent on the ongoing study of biology. Over the years, a number of different inflammatory mediators on the left have been identified that are associated with cachexia, and agents have been developed to evaluate their specific roles in cachexia. On the right, there are also a number of non-inflammatory factors, including GDF15 and others, that seem to mediate their effects on weight through CNS or neuroendocrine effects, and may be very important to the overall management of cachexia, and hopefully will be a subject for a future webinar to really explore the biology and therapeutic options that are moving forward in this field. But in conclusion, at this point, cancer cachexia is a complex disorder, biologically and clinically. Monitoring weight loss in our patients is really the best current method for early detection and treatment. Our current management of cancer cachexia includes a multimodal approach, nutritional counseling and support, as well as exercise and specific pharmacologic interventions that can be tailored to the patient's symptoms. With an improved understanding of the biology of cancer cachexia, we have promising novel agents currently in clinical trials that hopefully will address this major unmet medical need. With that, I'd like to thank you for your attention, and I look forward to the question and answer session.
Hi, this is Dr. Dave, one of the physicians at MD Anderson Cancer Center, working in the supportive care department. I'm going to briefly present a case on cachexia. This patient is a 72-year-old female with metastatic breast cancer, had extensive disease to the bone, left proximal femur, was undergoing standard therapy, getting active treatment, but due to nausea related to treatment, was referred to the Cachexia clinic. In our clinic, we noted intractable nausea, 10 out of 10, with occasional vomiting, significant anorexia with 35-pound weight loss, and the nausea was triggered by overeating, movement, and associated with diaphoresis above the neck. She had an extensive workup, which was unremarkable at an outside facility. She had treatment with Zofran, promethazine, meclizine, amitriptyline without benefits. Some of the workup resulted in treatment for possible migraines with Keppra, unfortunately, which was ineffective in controlling her symptoms. She denied rumination or anxiety triggering the nausea, but did acknowledge significant decrease in her quality of life secondary to the symptom burden. So in our clinic, we prescribed olanzapine 2.5 milligrams every 12 hours as needed. She was very reluctant to start additional medications, especially sedating medications. So we did start at a very low dose. We did recommend to wean off her anti-seizure medications. And then at follow-up, she actually did quite good. Nausea was 0 out of 10 without any anorexia or loss of appetite. She was gaining weight. She was taking it olanzapine 2.5 milligrams basically at night, which was also helping her sleep. She was actually doing quite well and was reluctant to get off the medication, secondary to concerns of having nausea related to her treatment. Now, olanzapine is increasingly used in supportive care for a host of symptoms. It's an atypical antipsychotic. Multiple randomized controlled trials show evidence in chemotherapy-induced nausea and vomiting and the prevention of that. More recently, it's being used for the treatment of anorexia. And in supportive care, we use it off-label for sleep and anxiety as well. It is important to also know some of the potential side effects of olanzapine. Common side effects that we see, orthostatic hypotension, weight gain, which sometimes we want in patients with cancer with complications of weight loss or cachexia. Akathisia is not uncommon at the higher doses, as well as extrapyramidal reactions. Some of the more rare side effects include QTc prolongation, so it's important to monitor the EKGs, also neutropenia and seizures. Now, cachexia is a significant burden to patients with cancer. It's associated with increased morbidity, decreased quality of life, and as in our patient presentation, increased psychological distress. Now, in our clinic, in our ambulatory supportive care clinic, we note anorexia in roughly 53% of the patient population, malnutrition risk using the PGSGA-SF in 61% of our patient population. And again, cachexia per various criteria in roughly 50 patients, 50% of our patient population. This is another data of a large database looking at the frequency of cancer cachexia in various cancers. And you see that breast cancer is not as common. Prevalence is a little bit above 20%. And the degree of weight loss is less, but every patient is unique. And in our patient case, the intractable nausea resulted in anorexia and weight loss. So one thing that we do highlight for our patients with weight loss is to treat what we call nutrition impact symptoms, things like nausea. Other symptoms include early satiety, which can be treated with metoclopramide. Treatment of constipation is very important. treatment of mood with mirtazapine can help improve weight loss. And other things like dysphagia or trouble swallowing or altered taste, dry mouth need meticulous treatment. This slide shows a kind of interesting point that anorexia is different from the process of cancer cachexia weight loss. We see that anorexia is strongly associated with emotional distress like anxiety, depression, while cancer cachexia is not so much. Unfortunately, cancer cachexia is due to the cancer host interactions, chronic inflammation, and hormonal abnormalities, which are as a result of, unfortunately, the underlying cancer. This is the randomized controlled trial recently published in 2023 that has evidence for olanzapine to prevent anorexia and improve weight. Olanzapine compared to placebo in adult cancer patients, either gastrointestinal or lung malignancies. And then the weight gain greater than 5% was in 60% of patients on treatment and only 9% of placebo. Appetite improvement was greater in the olanzapine arm, and also the anorexia score was improved on the olanzapine arm. Now, in patients with very advanced cancer, it is important to provide psychosocial support to patients and their caregivers. For patients with breast cancer, it's not uncommon to have body image distress, and it's important to have counseling also on the changing nature of nutritional needs. It's important to distinguish weight loss with starvation. And often patients may not necessarily have an appetite, but caregivers will have increased concern of patients starving to death. And cachexia has to be distinguished from starvation. It's also, unfortunately, there's limited pharmacological interventions. Meticulous oral care is needed. Monitoring for aspiration is needed, especially in patients with advanced disease. And then psychosocial counseling is important. These types of interventions are not well studied, but it is important to, again, aid emotional adaptation and coping, treat the anxiety and depression, which results from anorexia and weight loss, and then support treatment of nutrition impact symptoms and possible enrollment in clinical trials for the treatment of cancer cachexia. So, in summary of the non-pharmacological interventions, compassionate communication, nutritional counseling is also important to remove dietary restrictions. In general, recommendations are for small, frequent meals. Unfortunately, there's limited data to support this, but small, frequent meals are better tolerated by our patient populations. And targeting the calories to the kilogram weight of patients between 25 to 30 calories and between 1.5 to 2 grams of protein per kilogram per day. Also, exercise has anti-inflammatory benefits and promotes the maintenance of muscle mass. So it is important to encourage aerobic or resistance training. Unfortunately, the compliance in frail patients is poor. And then in conclusions, cachexia is associated with decreased survival, unfortunately decreased functional status, associated with other symptoms such as fatigue, body image distress is not uncommon, also associated with decreased response to treatment and increased toxicity. It is noted that both BMI and weight loss are important prognostic indicators. Body composition is quite important. Unfortunately, it's only done in the research setting. And then as a case exemplifies, treating nutrition impact symptoms like nausea aggressively can sometimes reverse cancer cachexia. Always consider non-pharmacological interventions, and then in the research setting, ideally to look at pharmacological interventions. And there's a few drugs that are coming out in phase 2 and phase 3 clinical trials that are interesting. And then also nutrition rehabilitation or cachexia clinics are important to develop. They allow treatment of this complex complication in patients with cancer, and allowing patients to have personalized treatment because not all patients are the same.
Thank you for joining. If you enjoyed today's episode, don't forget to share it with your colleagues and subscribe to our channel. If you'd like to learn more about cancer cachexia, you can access additional educational resources, including CME credit opportunities, on the Wiley Knowledge Hub. For more medical education from Wiley, visit Wiley Focus. All links are in the show notes. And don't forget to watch Part 3.